It has been said that whenever you give a lecture, you are lucky if the members of the audience can remember just 3 things. So I'm going to summarize this presentation by saying that this is difficult surgery. So this is tiger country, and this means that be prepared. You have to devote enough time for this operation that you can't go putting on several other operations on the same day. Schedule it for the first case. That way you might possibly enjoy lunch around about 3 p.m. When you've done that, just recognize that there are errors of omission and commission. The commission, I've talked about repairing serosal tears when you see them, and omission is to leave the bowel dilated. So there are several risk factors which you'll know up front are going to be areas of difficulty in a particular case. I think this one's Dr. Abkarian when he sort of challenged a bull somewhere in Mexico. But if you've got a large pelvic tumor, which is advanced, if it's reoperation in the pelvis, for example, you've had a colorectal anastomosis and a leak, and there's been time for a big adherent scar to develop, that'll make it difficult. Variations in the anatomy. You have to recognize that sometimes the left ureter crosses the midline and comes down the right pelvis. If you have a short rectal stump, sometimes surgeons, especially with IBD, will take this down to an area which I call an in-between. It would have been better to leave inflamed sigmoid, for example, make a sigmoid mucus fistula and ileostomy after an abdominal colectomy than it is to leave the very short rectal stump, which can make for extremely difficult reoperation. I think Dr. Delaney's talking about this later. Any chronic pelvic sepsis, poor risk patient, or the surgeon's inexperienced. I mean, you're just not the sort of case you want the first week that you're out there in private practice. So, as Clint Eastwood would say, a man or woman has to know their limitations, and if it's got a lot of adverse indicators, then try to stay away from it. I've mentioned this already. You have to keep a running account of how your case is going with the anesthesiologist. Make sure you have blood. Make sure you've got good visibility. I like different sets of retractors, which are like a variation of the Brabby retractor. I've got one that's named after me, that last one, on the left. But basically, it's a way of getting good illumination and being able to elevate the structure you're retracting, whether it's the bladder or vagina or whatever. So I use different sets of lighted instruments, and for pelvic reoperation, always, repeat, always put in ureteric stents by your friendly neighborhood urologist who can slip them in usually fairly well. So you try to get a roadmap. First of all, you correct the correctable deficiencies. Try and get a roadmap to identify the planes where you know you'll be drifting into, and then you try to study if the patient has bilateral renal function. Because at the end of the day, you may be faced with a very difficult choice of having to do a nephrectomy as part of the operation, and you're not giving the patient any help by taking this out when the other kidney is non-functioning. So this is not a case for laparoscopic surgery or robotic surgery or single port surgery, unless you're a maniac and you like to be masochistic. So you use big incisions, you get into the abdomen, usually the least fixed portion is above the umbilicus, and you leave any fixed fistula attached until you've snuck up on it from above and below to get access to it. I use a C-arm. Patient's arms are by the side because the surgeon may have to go from one side of the abdomen to the other, one side of the patient to the other to get optimal access. So we use stirrups, bimanual palpation during the course of this. If a patient has a rectum and a vagina, then we'll use by manual palpation, presacral dissection. Now, part of this talk, which I'm not going to go into in detail, is on pelvic hemorrhage. Pelvic hemorrhage is one of the bad things that can happen to you during the course of an operation. And if you can hear it bleeding, you know you're in big trouble. Now, I was taught a little bit about this by Dr. Harry Abkarian, who I don't want to say he's an expert in pelvic hemorrhage, but he's pretty much an expert in how to handle it when or if it occurs. Now, the mid-presacral dissection is where it's possible to injure the basivertebral veins, and this is where you have to pay attention to control. So if the rectal stump has been previously tagged, it will help you identify it, but you try to identify the fixed structures, those which are there in every case. The promontory of the sacrum is always there. The rectal stump may be buried by scar tissue, but you've got an obturator down below that can be pushed up to identify it, or an educated index finger if it's low enough down. This is important because I've had to, defend cases in which surgeons have taken recourse into an age-old remedy of an anastomosis made in difficult circumstances. The circular stapler is placed transanally, EEA or the Ethicon product, and after the cap is taken off, the trocar is passed through the anastomosis, through the stapled over closure. And of course, it's sort of like baseball. Some good things can happen, like getting it through without injury, but bad things can include sticking it into an adjacent viscus, or that when you close the anvil on the circular stapler head, you'll incorporate a piece of vagina or a piece of bladder, and then you're really in all sorts of difficulties. So, one of the ways of trying to expose the difficult rectum when you've had to transect it low down is to use fist pressure to help elevate where you're working. And this will help, especially if you've got a lot of scar tissue overlying the top of the rectum or the stump there. In cases like that, however, one would be better advised to consider a mucosectomy and then do a pull-through operation where you exteriorize the distal end, because that's going to pose some difficulties of access as well as completing it. In some patients, there is this, what I call a crescent moon appearance, where there is a fibrous ring that passes from left to right or right to left across the base, and this is like dense scar that helps prevent you from getting full access to the deep pelvis. Take note of the fact that you can buy your way out of that. It does require bilateral, superficial, not deep, cautery incisions over the scar tissue, and then by making sure that still the ureteric stents are in place, then trying to mobilize the distal rectum a bit more anteriorly, and that can be facilitated with a red rubber or other form of catheter. So this is the hydrodissection I'm talking about, where you're injecting the space between the vagina, in this case, and the rectal stump to enlarge that gap that will allow you to dissect in between those two structures with lessened risk of an inadvertent vaginotomy or a proctotomy, which is made so low down it commits you immediately to having to remove the rest of the rectum, possibly with an abdominoperineal resection, although there's always the pull-through operation to get you out of this. Another problem we sometimes encounter is that the rectal stump is fused to the promontory of the sacrum. Take heart, because the same principles apply about hydrodissection, identifying the ureters, and getting that plane of dissection. If worst comes to worst and you cut into the top of the rectum, take heart, because there is always one or other forms of the pull-through operation that will extricate you from this. I always try to mobilize distal to proximal. When doing this operation, often described, but the consequences of it are not, and that is the telescoping of the distal rectum as you're trying to pass the trocar through the top into the distal colon with a stapler head attached. Now, this phenomenon of concertinaing will in effect lead to a very large tissue ring or donut, which in turn will almost certainly mean an anastomotic leak, which you can identify at surgery with air insufflation or betadine injection of the rectum. Far better to do this. If there is scar attached to the top, as is demonstrated in this where it's been stapled across, to do a end of colon to side of rectum anastomosis. This leaves a small gap there of bowel where it is possible for inspissated stool to get there. But that's far better to have that and an intact anastomosis where distal irrigation of the stump can be carried out. So, there are a number of intraoperative strategies that can be used. Not quite sure, Mr. Moderator, if I have 1 minute, 5 minutes. What? I'm not going to get the hook and dragged off. Okay. Just use a soft one if you have it. So, use sharp dissection of the presacral space. Now, Dr. Abkarian taught me many of these things too. And you have to remember the differences between benign and malignant disease. There's no traffic signs or flags waving that tells you what it is. You have to assume, in many cases, that this scar tissue could be recurrent cancer, unless you're doing it for benign disease. So this is something to be fully aware of, and if necessary, use frozen sections to tell the difference. Isolate the nerves. That's easier said than done because the presacral plexuses, like filaments of lace, hard to find, but you can usually find the presacral nerves because they're thick structures, same dimension as spaghetti, and you try to preserve those for future, especially male sexual function, but also female sexual function. I like to use the bimanual exam where I've got a finger in the patient's anus and I've got a hand going down the pelvis to try to isolate where the two are coming together and at the same time try to appreciate what the scar tissue density is like at the top of the rectum, because that will tell you if it is feasible, not feasible, if it is appropriate to drive the trocar through that staple line. And if there's a bunch of dense scar there, it is not. It is far better then to just assume that when that happens, you will get an anastomotic leak, incomplete donuts, and then you're in a real pickle because at some point, if the patient wants to avoid a permanent ostomy, you'll have to go back there. If there's one thing worse than doing a reoperative pelvic surgery, it's redoing it for the second, third, or fourth time. So, I like to use the lighted instruments as I demonstrated there a little bit earlier. Here's this side to end anastomosis, which means you don't have to dissect around the top of the rectum, but of course it does mean also you have to have enough rectum to be able to do this, which will require some anterior dissection, possibly with hydrodissection. This is another way of showing how far down you are with bimanual palpation. Pelvic bleeding, I wasn't going to get into this too much, but I'll go quickly through some of it. That can occur in a number of ways. The presacral, lateral sacral veins and breaching of the presacral fascia and internal iliac vein bleeding. You know when that occurs, it's almost audible bleeding because the blood just rushes up and you're hard pressed to be able to suck the blood out fast enough to get a good view. So you have to presuppose that's going to happen. It'd be pretty clever, it would be pretty smart to have blood cross-match for surgery, probably 4 or 6 units depending upon the complexity of the case, and to make sure that coagulopathy has been excluded or corrected prior to the surgery. The ones that are the most commonly the problematic are those that are the basivertebral veins, these veins which have no muscle coat, which perforate through the sacrum, go to the supply the distal rectum, but also as problematic almost is bleeding from the rectovaginal or retroprostatic, I misspelled that word, prostatic veins, or as I mentioned, the presacral veins. Now, these sorts of things can be extremely difficult to handle, and you don't want to waste your time trying to suture, close them. All that does is make it worse as a rule. So you accept the fact that you've got bleeding there which is difficult to control, and the first thing one does is try to identify where the bleeding point is. Now, remember, a retractor even, or your hand, is going to obscure your view. You can't get a good look at it, so use something else, like a sponge stick, to force the posterior structures backwards and get a good look at it. Here's the mechanism of the injury, and I thank Dr. Harry Abkarian for this, where you can see in the bottom left-hand picture how these vessels can be torn, and which are then rendered almost useless trying to sew those things together. So here are these muscle coat-less vessels coming through, and here you'll often see described the thumbtack. Let me tell you about thumbtacks. I mean, one of the big events in management was to put these, I don't know if I've got a light here, but no, that's volume, whatever. But you can see that there are ridges on the shaft of the thumbtack, which helps firmly place it into a structure like the sacrum and keep it in position. Often easier said than done. Just use a thumbtack. Ain't so easy. It requires different attacks. Here's one where a person's trying to put their finger on there. It's darn hard, I can tell you, when you're pressing it into bone. So I like to use a large scissors, what I call the Jones scissors. They're about the width of your thumb, and you drive that in to maintain the this in position. So here are the steps one goes through. Early on, use your index finger to control. See if you can control it, then suck around it till you get a good look. And if you can't, you have to pack the pelvis. Now, packing is not simply stuffing a pack or 2 or 4 or 6 packs in there. It doesn't work that way. You try and put that in, and somehow that blood finds a way of coming up and escaping around it, and the next thing you know, you're having to say, well, look, I don't think this is handling it. It does give you time to tell the anesthesiologist what's going on, so it gives them time to order more blood if necessary. But this is a very proactive procedure to pack the pelvis. You have to put it into the presacral space, and if it's the back of the vagina or prostate that's bleeding, you have to be able to elevate that packing low down to be able to control it. And you'll know that when you see it, because it will stop that bleeding almost magically. So you have to try to optimize your lighting exposure. See if you can control it with point pressure. The point pressure is not so much to be able to get a suture out and try and suture close it. Of course, invariably that will simply make it worse. But it does give you a point of reference so that you can use such things as tamponade. You take a strip of the rectus abdominis muscle, usually from the left side, and this 2 centimeter by 2 centimeter piece of muscle is put down there with sutures placed on either side of it and then tied down after they've all been placed. That muscle tamponade is what will work. If you can't do that, you can have a backup plan, which is to get a long Kelly clamp attached to that muscle segment that you've mobilized, put it down so it's now controlling the bleeding, and then cauterize it. You turn the, anyone see Star Wars or Dr. James Tiberius Kirk with their phases? We don't have those. But we do have cautery, which means you can hold the muscle segment on the bleeding point, control it, and then cauterize the Kelly clamp. And that will often dissipate the heat energy to that area at the same time. So that's another way of getting out of this, or go back to packing again. And the packing, again, you might say, well, that's going to cause inability to do an anastomosis. Not so. You can still do an anastomosis, a low rectal, or even a pull-through. But to do that, you have to weigh in the balance the risk that this will cause sepsis, which will go into the anastomosis and cause what is a really difficult thing, which is a low colorectal anastomotic fistula. Now, with all of these anastomoses we do, and I think Dr. Senegal is going to talk about this a little bit later on, but I'm sort of substituting for him in a way. You test the anastomosis with air or betadine or something like that. And if you can see a defect, that's when you will suture it at that time. But remember, you're down in this hellhole. You're really struggling. You know, the nurses are tapping their feet or drumming their fingers, anesthesiologists are getting out the newspaper to read. And then you have to say, what am I going to do next? What next? Because if you can repair that at that time, that is head and shoulders above just packing it, hoping that none of the bad things happen, because you're going to have to go back and operate on that patient again, independent of the ostomy closure, which you will always use, I might add. So we've devised an instrument, which is an old instrument. It's called a boomerang needle, which has a curvature on it. I don't have a picture to show you, but it's got at the very tip of it a hole where you can put a suture. And this boomerang needle has the advantage of being able to place pretty exactly without obscuring your vision, because it's only the vision being obscured is the shaft of this particular instrument. And so you can place several of these. Don't tie it right there and then, because you've got your pack down there to cause pressure, and then tie this down over the defect. So you can do a direct repair of these defects as they occur. It is far better to do a primary closure of this, because after all, you're trying to do that. If you had a leak from a ileocolic anastomosis, you'd simply repair it. Piece of cake, you can easily see what you're doing. But down the pelvis, you can't. That's why we talk about using those stirrups. So the sponge holding first of his finger, pack again to control. Now, rarely you'll get a situation where you can't do anything. You've got a cell saver running, you're telling the anesthesiologist, you know, don't go anywhere, and packing. Now, on one occasion, I was called in to see one of the orthopedists who was doing a hemisacrectomy. Forgot what reason for, maybe a chordoma. But in any event, there was bleeding like stink coming out of the pelvis there. Everything he had, bone wax, pressure, all that wouldn't work. And he said, I'm going to try something I've never seen before, let alone observed. He got out a thermos of liquid nitrogen. I couldn't believe it. He poured this stuff into the pelvis there, instant freezing there, all stopped bleeding. And I thought, God, he's going to cause necrosis of the whole sacrum and the other vessels around. But anyway, that actually worked in that case. I'm not advising that, but saying that these are the extent to which you can try to get out of it. Ligation of the internal iliac veins, commonly written about. I found it rarely does any good. And what's more, this is often in a radiated pelvis, so that if you're putting a right angle clamp around an internal iliac vein and you're trying to then tie it off, what you end up doing is putting a bigger puncture in the vein itself, and then you're forced to go into your 5-0 proline or something like that to close it. Not always easy to do. So that, in a nutshell, is reoperative pelvic surgery. If you're smart, you'll transfer the case to somewhere else, but if you're like us, you know, you're the end of the line and the last port of call, then you're stuck with it. Thanks very much.
Thank you so much for this marvelous talk. Thank you.